Hi, it's Dr. Terry. In this slide set, we're going to be running through our second year clinical skills curriculum for psychiatry. This is to be part of a general clinical skills course and is not meant to be a standalone psychiatry course, nor is it meant to be comprehensive like a 4-year psychiatry residency. Today we'll be covering psychiatric differential diagnoses, assessment, and plans, and picking up on where we left off after my first year course. That video is also available. If you need that link, let me know. I'd be happy to get that to you. Our session learning objectives are primarily going to focus on a follow-up psychiatric visit or a follow-up in a primary care office for a patient presenting with psychiatric concerns. We're going to discern and rank psychiatric versus non-psychiatric presentations as part of a differential diagnosis. We'll take a look at treatment options for common conditions. I'd like you to also know when to refer to psychiatry for specialty evaluation and treatment. And finally, we're going to integrate cumulative principles from our behavioral science and psychiatry course and build upon what we learned last year in the developing physician course in your growth as an osteopathic physician. Let's take a look at some definitions. This slide may be familiar to you because it is a repeat of a slide that I used in my first year curriculum that runs through a number of common definitions and terms that we use in psychiatry. If you need to pause here and refresh your memory, please do, so you can take a look at each of these definitions. You should be able to discern and distinguish between the differences in some of the overlapping and similar terms. This slide is a nice reminder about the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders Text Revision, which as of the time of this recording is the most current resource that we use for inter-rater reliability among mental health professionals and medical professionals to make sure that we're talking about the same diagnoses. This is also a nice reminder that the largest consumers in both primary care and emergency settings are patients with comorbid psychiatric or mental health concerns. An overwhelming percentage, from 50 to 75% of the diagnoses are undetected or untreated, but may be some of the most pressing reasons why the person is in each of these settings seeking out help. 50% of outpatient visits involve physical symptoms, and at least 1/3 of those symptoms may be unexplained, and they don't correlate well with a known physical diagnosis. We also know that the prevalence of anxiety and depression increases in patients with unexplained symptoms. More on this later. Finally, we should be aware that common functional syndromes, such as IBS, fibromyalgia, chronic fatigue, and even TMJ are commonly associated with co-occurring mental health symptoms or diagnoses, and looking for those overlapping symptoms is going to be of critical importance. Now, if you're in my second year course, I'm going to want you to be very comfortable with a follow-up visit, taking a look at psychiatric concerns. The 4 questions that I want medical students to be very comfortable asking patients about follow these general patterns. There's the first question, which is hey, how are you, Mr. or Miss Patient? What's going on? And that's to build rapport and also establish a chief complaint. I'd like to know how the patient's treatment, if they have a treatment, is working for them, which helps to address symptoms and adherence. I'll also ask the patient if they're having any side effects or problems, and making sure that I don't miss any symptoms related to, say, black box warnings or things that we absolutely cannot miss. And then a last question, building upon the ethical principle of autonomy, is I'll ask the patient what changes, if any, they would like to make. Again, these are the 4 questions that I would advise any medical student to be comfortable with, so that once you're in clinical rotations or in residency, you can walk into a room and be able to carry out basic functions of a history as needed for a follow-up visit. Now, these slides are some that I borrowed from the ASCP course because I thought they were just so good. And what this talks about is in non-psychiatric settings, the prevalence of mental disorders is incredible. Likewise, the greatest utilizers of general medical care have comorbid panic disorder, generalized anxiety disorder, or depressive symptoms, and the top 10% of utilizers, this sounds like an insurance term, but the top 10% of utilizers account for 29% of all primary care visits, 52% of all specialty visits, 40% of in-hospital stays, and 26% of all prescriptions. A way of looking at this is if your plan is to avoid psychiatry entirely, I have some bad news for you, because psychiatry is everywhere in medicine, and the patients that we're going to be seeing most frequently are those who do have overlapping psychiatric concerns. Treatment of those psychiatric concerns is likely to result in positive outcomes not only for the patient's psychiatric symptoms, but also for their physical symptoms and diagnoses. We also know that there are tremendous cost savings that are associated. For example, if we treat panic disorder in primary care, we see that there's lower service utilization, there's less use of sick days, there's yearly savings, which becomes important to our administrators and payers. We also see that psychiatric diagnoses, as a reminder, are all diagnoses of exclusion. To give somebody a primary psychiatric diagnosis, that is to say that it is not due to a general medical condition, it is not due to substance use or withdrawal, it is not due to iatrogenic effects of treatment, nor is it due to some other psychiatric or developmental disorder. So let's talk about anxiety. For this, I'm going to show you a quick memorable photo here of Noodle Terry, who's a very, very good boy who really, really does not like his shoes. And because of where we live and how hot the pavement is, we've been trying to get him used to his shoes, but his shoes cause him a significant amount of anxiety. Now, this shouldn't come as a surprise to anyone, but patients with anxiety are so frequently visiting general medical settings, including emergency rooms and primary care visits, but interestingly, much less so are they seen in mental health. Some of that might be just a numbers game. Some of it might be related to stigma. When you combine those things with the difficulty in accessing mental health, and then stigma for taking time off of work or school to take care of mental health needs, we can appreciate how so many more patients have treatment for their anxiety and their presentation in non-mental health settings. The presenting symptoms of anxiety in primary care may be related to central nervous system symptoms, heart symptoms, GI, lung, alcohol-related, and you'll notice that actually a minority of patients, right around 10%, actually describe psychiatric symptoms such as I'm having anxiety for what is really anxiety. We also see that general medical illnesses are commonly associated with anxiety symptoms. In irritable bowel syndrome, up to 30% of patients may have anxiety symptoms. Hyperthyroidism, it's 60%. Coronary artery disease, it can be 1 in every 2 patients. And chronic obstructive lung disease can be as high as 67%. If you think about it, for a patient who has chest pain or for a patient who has difficulty breathing, these can be very anxiety-provoking experiences. If we think about anxiety in this sense, it's a tool that actually we have evolved to have to survive. When we feel anxious about what we're experiencing, it might keep us safe, or it might cause us to seek some type of intervention or get help so that we don't expose the individual or the group to any additional risk. These are cases that we'll explore more in class. Case 1 involves a 29-year-old male who has crampy abdominal pain, bloating, diarrhea, gas, and food intolerances, along with episodes of anxiety and numerous ineffective treatments. We might consider ways in which this patient's symptoms cause them to feel anxiety, as well as how their anxiety may cause them to have symptoms. Similarly, we may think of a 42-year-old female who presents to the emergency room with crushing chest pain. She's had numerous emergency department visits and no shortage of workup, including 3 stress tests and 2 inpatient admissions. She's had a normal angiogram, but also has a family history of anxiety. In this case again, we might think about how the patient's anxiety impacts her physical symptoms, as well as how her physical symptoms impact her anxiety. This slide picks up nicely on the 2 cases we just discussed. If we take a look at anxiety and gastroenterology, the prevalence of irritable bowel syndrome in the US is about 10 to 17%, but almost a third of patients with IBS have anxiety, and 44% of patients with anxiety may have IBS at some point during their anxiety symptoms. Interestingly, if you treat the anxiety, both syndromes will improve. If we think about our second case, anxiety and cardiac disease is also incredibly common. Anxiety happens in people with normal coronary arteries, And it also happens, of course, when there's chest pain or if there's ischemia. We also have, with paroxysmal atrial tachycardia as anxiety, a high amount of misdiagnosis, delays in diagnosis, and also that if a patient has their tachycardia treated, they can also have a resolution of their anxiety symptoms. What are the takeaways from this? If a person presents with both anxiety and physical complaints, treatment of the anxiety can help to address the physical complaints, and treatment of physical complaints can help to resolve the anxiety. As physicians, we want to be sensitive to the needs of our patients, whether they present as physical or psychiatric. People often confuse stress and anxiety. I want to emphasize that stress is not a DSM-5 diagnosis. However, for anxiety, there are many different anxiety disorders that fall into a range of measurable symptoms, behaviors, and durations of those symptoms, experiences, or behaviors. The most prevalent anxiety disorder that primary care populations present with is generalized anxiety disorder, commonly referred to as GAD. Now, generalized anxiety disorder can be thought of as excessive worrying about things, lasting more than 6 months. It's often defined by realistic worries and the what-ifs about events that could happen. So it's not necessarily about things that are unrealistic. It's not related to panic attacks, as we'd see in panic disorder. It's not related often to traumatic experience, such as in acute stress disorder or post-traumatic stress disorder. And it's not related to specific fears, such as phobias. There are screening questions that an interviewer might ask. Have you ever felt nervous or anxious in the last few weeks? Do you have difficulty to stop or control worrying? Have you had an anxiety attack or a sudden feeling of fear or panic? And did something cause you to feel this way? Now, a spoiler for our second-year medical students about to go into their psychiatry course, if something caused the anxiety, it might not specifically be generalized anxiety disorder. We might be more looking at an adjustment disorder, which is a type of anxiety that's caused by a specific event that occurred in the person's life. This is a reminder about the GAD-7 assessment tool or screening instrument that's commonly used in primary care. The GAD-7, or the Generalized Anxiety Disorder 7, is a questionnaire that goes through 7 key symptoms related to generalized anxiety disorder and then asks a final question about how difficult these problems have made it for the person taking the assessment to do their work, to take care of things at home, or to get along with other people. Keep in mind the GAD-7 is a screening tool, but it is not a diagnosis. Similarly, depression is a symptom. Having a depressed mood is not a diagnosis. Depression itself, or feeling depressed, can be situational. It could be reactive. For example, it could be due to a death in the family, a bad test grade, a broken car, receiving bad news, or something else that causes us to feel down or feel depressed. Sometimes feeling depressed can be due to some other medical process. We commonly think of hypothyroidism, endocrine issues, and perhaps difficulty with breathing or cardiovascular problems as being associated with depressed mood. There's also tremendous overlap between patients with neurologic disorders such as stroke survivors. Depression can also be part of some other psychiatric disorder. I want to keep in mind that major depressive disorder, for example, is one diagnosis that includes a depressed mood as a primary feature, as does adjustment disorder with depressed mood, bipolar disorder, schizoaffective disorder, depression due to a general medical condition, or substance-induced disorders. Again, I want to emphasize depression, like anxiety, is a symptom, but not a full diagnosis. Let's bring our understanding of depression to a case that we'll discuss in class. In this case, we have a 27-year-old female with insulin-dependent diabetes mellitus. The patient's disorder is described as being brittle with early retinopathy. She has been non-adherent with medications and has frequent visits as well as missed visits. She also identifies having a poor work performance, poor sleep, low energy, no interest in her hobbies, and a depressed mood. The This range of symptoms that we're going through might sound a little bit like a memory tool that we use with medical students that refers to the symptoms of depression as they're described in the DSM-5. Rather, I should say the symptoms of a major depressive episode. Those symptoms, spelled out as SIG-E caps, speak to changes in sleep, changes in a person's interest, feelings of guilt, changes in their energy, decreased concentration, changes in appetite, either too much or too little, psychomotor agitation or psychomotor slowing, and the last one that we certainly don't want to miss, any type of suicidal ideation. In order to diagnose major depressive disorder, we first need a depressive episode, which is defined as a depressed mood and at least 4 other symptoms present every day for at least 2 weeks. The symptoms outlined in a depressive episode are very well accounted for on the PHQ-2 and the PHQ-9. PHQ stands for Patient Health Questionnaire, and the 2 or the 9 refers to the number of questions that are assessed on each of these screening instruments. Generally, if a patient has a positive PHQ-2, you may expand and do a PHQ-9. However, if a patient has a PHQ-9, because that is the more detailed assessment, there'd be no reason to go back and do the PHQ-2. The PHQ assessments are frequently and easily assessed on multiple choice because unlike the GAD-7, the PHQ does not correspond with letters that make a student or a learner think about depressive symptoms. So from this point forward, please remember that the Patient Health Questionnaire is a screening instrument used for depression. Similarly, the PHQ is not diagnostic. It's a screening instrument that should lead the clinician down a road of asking more questions and seeking out greater diagnostic clarity. The second-year osteopathic medical student should also be very familiar with screening for substance use disorders. I want to discuss with you a case of a 52-year-old male. This gentleman has alcohol use disorder and frequent drinking behaviors. He's also been found to have liver insufficiency, has lost his job, feels depressed, is not sleeping, and has suicidal thoughts that are worse when intoxicated. His family has disowned him. He enters the emergency room at 10 p.m. on Saturday night, and there's no psychiatrist there to see this patient. What scale can be used as a screening instrument to better assess this gentleman's presenting problems? If you said the CAGE questionnaire, you are correct. The CAGE questionnaire is a screening instrument that works for any addictive behavior or substance use disorder, although it has been most extensively studied and applied in the use of alcohol use disorder screening. The C in the CAGE questionnaire asks, have you ever felt you should cut down on your drinking? The A stands for, have people annoyed you by criticizing your drinking? The G asks the person, have you ever felt guilty about your drinking? And the E asks, have you ever had a drink first thing in the morning as an eye-opener? Each of these questions is scored with 1 point, and higher scores are more diagnostic of alcohol use disorders. Now, we have to remember that the use of alcohol is incredibly common in the United States, with some areas being a very strong part of the culture or what patients may do in their behaviors. We should also remember that prescription drugs, at least as of the time of this recording, are the leading cause of drug-induced death. We're going to transition into some material now that we did not cover in the first year course. We'll run through some additional disorders that I'd like you to be aware of and keep on your differential. Now, these are disorders that we're going to discuss again in the Behavioral Sciences and Psychiatry course, but I want you, again, to be familiar with them from a general clinical perspective, as we would expect in the Practicing Physician course. The most common mood pathology in bipolar disorder is actually depression. Many people might think that manic or hypomanic moods refer to bipolar disorder, and those are characteristic of how a person with that disorder spends the majority of their time. Actually, if a person has bipolar disorder and they have mood symptoms presently, they're more likely to be depressed than anything. However, you should be familiar with the symptoms of hypomania and mania. An acronym that we use for that is this DIG FAST acronym. I'm going to allow you to pause the slide if you want to get a little bit more familiar with the distractibility, insomnia, grandiosity, flight of ideas, activities, speech, and thoughtlessness patterns that can be used for screening a person for mania or hypomania. Due to the prevalence of trauma in our patient populations, you should also be familiar with post-traumatic stress disorder, or PTSD. PTSD is interesting because it's associated with symptoms that overlap with both anxiety and mood disorders, and PTSD actually was classified as an anxiety disorder in the DSM until 2013. We'll go through some of the criteria here for post-traumatic stress disorder, and I'd like you to be aware that mood, cognition, and perceptual abnormalities are found in PTSD, not to mention ADHD and other psychiatric diagnoses. We'll go into a little bit more about how to discern between these different areas in the next slides. In order to meet criteria for post-traumatic stress disorder, a patient has to have had actual or threatened death, serious injury, or sexual violence in one or more of the following ways. They might have directly experienced the event, they might have witnessed in person the event, they might have learned the event occurred to a close family member, and they maybe had been exposed to repeated or extreme exposure to aversive details of the traumatic event. For example, first responders collecting remains, police officers repeatedly exposed to details of child abuse, things that expose a person to trauma and traumatic events that they might not otherwise have exposure to. Now, because of that actual, threatened, witnessed, or perceived event, the person now has intrusive symptoms that are associated with the traumatic event. It might include recurrent involuntary intrusive memories, dreams, and dissociative reactions, such as flashbacks. It can include intense psychological and psychological distress in response to cues that symbolize or resemble an aspect of the traumatic event. It might include avoidance of stimuli associated with the trauma. There might be negative alterations in cognition and mood associated with the traumatic event. And they might have marked alterations in arousal and reactivity, evidenced by two or more of the following: difficulty falling or staying asleep, reckless or self-destructive behavior, irritability, difficulty concentrating, hypervigilance, or an exaggerated startle response. Keep in mind here, when you're looking at post-traumatic stress disorder, you have a person who has experienced, by definition, something traumatic, and now their life is different because of that. And the symptoms and behaviors that they have because of the trauma impact that person's function. In preparing medical students for choosing a career in psychiatry versus other disciplines, we're already starting to see the tremendous amount of overlap and nuance that exists in psychiatric diagnoses. For example, we've seen that patients with anxiety also have often mood features. For patients who are depressed, it's very common for that to overlap with anxiety. For patients with post-traumatic stress disorder or trauma in their life, of course they go on to develop symptoms related to anxiety and depression. So I can't emphasize enough that accurate diagnosis is really going to help to inform not only what treatment we provide, but also at what level of care that treatment is issued. Is this something that can be handled as an outpatient, or is it something that requires hospitalization? Is it something that requires referral? Those are all things that we need to talk about. When we do have patients who approach us with psychiatric symptoms or concerns, we as clinicians, whether or not we are primarily in psychiatry, want to focus on relieving that person's symptoms as rapidly and safely as possible, preventing further episodes, eliminating anticipatory symptoms and avoidance behaviors, controlling comorbid conditions, and improving quality of life. We want to emphasize, especially in our world that has so much stigma around mental health diagnoses and treatment, that anxiety and depression are medical illnesses. Treatments are effective, and the aim of treatment is complete symptom remission as often as we can achieve that. However, a risk of recurrence is significant, and to encourage a person to be welcomed and invited to seek treatment early if their anxiety, depression, or other mental health symptoms return. As we mentioned earlier in the slide set, the majority of patients with psychiatric concerns are actually not seen by psychiatrists. Most are seen in primary care community settings. For that reason, it's important to know which patients should be prioritized for referral to psychiatrist versus those that really are quite fine in primary care settings. Most primary care physicians should feel very comfortable managing depression, managing anxiety, managing common things. However, if you do have a patient who's manic or psychotic, who's actively experiencing suicidal thoughts, if there's significant psychosocial issues that can't be addressed in a primary care office, such as housing, placement, or conservatorship, or perhaps most importantly, if symptoms are outside of the professional's level of comfort, then we absolutely welcome a referral to a psychiatrist. On the slide, I've included photos of 2 psychiatrists that, if you don't recognize, you might recognize very soon. Suicide risk, not to be confused with the suicide squad, is something that every physician should be comfortable assessing. Again, psychiatrists are not always available, and patients who are at risk of self-harm or suicide are going to be present in many primary care and emergency populations. These include patients with a diagnosis of cancer, where we see in the first year the relative risk of suicide is actually up to 16 times that of the general population. Interestingly, perhaps as there's peace and acceptance made with the diagnosis, this risk actually decreases over time, and for those who survive cancer, by year 10, it's less than half that of the general population. We don't see as many patients with AIDS as we used to, but suicide risk is also elevated in patients with this diagnosis. We should also point out that patients with some diagnosed psychiatric illnesses include a risk of suicide that's 25 times that of the general population. Suicide overall is the 12th leading cause of death in the United States, and it accounts for more than 40,000 deaths per year. It's the second leading cause of death among 15 to 24-year-olds. Rates are highest in 45 to 54-year-olds, and then followed by those who are greater than age 85. You should note that suicide rates themselves are 4 times higher in men versus women. However, women are 3 times more likely than men to attempt but not to complete suicide. A screening question to ask is, have you ever thought of harming yourself or others? As well as, have you ever attempted suicide? If the person, of course, says yes to any of these, it'll be important to figure out when, why, how, and is this a current risk? I'd like you to please learn now and to forever remember that asking about suicide or homicide does not make a patient more likely to act upon those thoughts. It's not as if you're suddenly going to give them permission or make them think of these things if they weren't already doing that. You should also be familiar with the 1976 precedent Tarasoff case, also known as the duty to protect. This applies when a patient makes a threat to a physician or therapist of serious violence or bodily harm against a reasonably identifiable victim. This becomes one of those times when it's okay to break confidentiality within reason to make sure to do what is needed to keep the victim safe. Again, it's essential for every physician to be comfortable performing general risk assessments. The goal of a risk assessment is to identify patients at a high risk of suicide and to lower that risk. And we remember that a risk assessment in itself is not suicide prediction, nor is it necessarily suicide prevention. However, it can be along those lines. It's important to ask about and to be able to differentiate between intent, plan, and means. Intent describes a clear desire to complete suicide, but that can change with the situation. Questions might include, have you ever thought about hurting yourself or ending your life? Intent is different than this word ideation that gets thrown around all the time in clinical settings. Ideation is much more vague, and that refers to general thoughts or preoccupations with a topic, but saying a patient has suicidal or homicidal ideation doesn't tell me if they actually have intent right now or if they've had intent in the past. It's essential for the student doctor to also be comfortable asking about a plan. A plan is a realistic and achievable method by which the patient may complete or attempt suicide. A question to get to this would be, do you have a plan for how you would harm or kill yourself? Finally, we ask about means. Does a person have access to the method that the patient is planning? For example, do they have access to firearms? Do they have medications if they tell you that their plan is to overdose on medications? Do they have a rope and something to hang off of if they talk about hanging? It's okay to get very specific about means, and physicians should feel very comfortable asking questions related to these topics because they are critically important. I can promise if these questions are uncomfortable or difficult for you to ask about, it's going to be even more difficult or uncomfortable for the patient. When we talk about end of life and suicide issues, it spills into ethical concerns and philosophical concerns that will not adequately be covered in this presentation. However, in our clinical skills, the student doctor should be comfortable with asking about suicidal thoughts and performing the PHQ-9, which we'll remember, the Patient Health Questionnaire 9, is the assessment or the screening instrument that can be done in primary care settings to screen a person for depressive symptoms, which includes suicide. The treatment and what is recommended really depends upon the diagnosis. For example, if a patient's suicide risk is due to depression or psychosis, then it's within the physician's purview to treat those underlying disorders. The doctor can also treat causative or contributory medical factors, including but not limited to intoxication. We talked about chronic illness. The doctor could also assess the patient's degree of impulsivity or reactivity. If there's a crisis going on or an acute psychosocial issue, it might make sense to withdraw the patient to keep them safe from whatever's going on in their setting. As I mentioned, there are philosophical issues, often relayed in the literature and in physician discussions of a patient's right to die. Again, those are outside the scope of this conversation, but you should be familiar with treating a person's pain if the pain is the reason why they wish to end their life, as well as invoking the help of relatives and social supports, and also helping a patient explore alternatives to dying if alternatives exist. In a basic second-year clinical skills course, the student doctor should be familiar with basic treatments for depression and what sort of outcomes and timelines might be appropriate. Patient education and reassurance can always be provided at the same visit so long as the patient's able to listen and integrate that information. Psychotherapy may have immediate results, or you may see additional results and gains over the coming weeks to months. Medication in general can take 3 to 6 weeks to become fully effective and to reach its plateau, though I'll often advise patients that really the medication does begin working immediately even if the changes continue to build. Electroconvulsive therapy or ECT can be very effective and work very quickly within 1 to 3 weeks. Light therapy for seasonal affective disorder should be remembered and considered. And then other options such as transcranial magnetic stimulation, vagal stimulation, these are a little bit more esoteric and not something that I would expect to be immediately testable at this point in your training, but they are things that you should be familiar with and things for which you might refer to a specialist. CBT or cognitive behavioral therapy is highly effective in moderate anxiety and depression and is a great initial treatment choice, especially for those who are not interested in taking a medication. You should also note that medications are going to be most effective for those with the most severe symptoms. That's not to say that medications are ineffective for those with mild or moderate symptoms. Those patients just don't have, for example, as high of a score on a PHQ-9 to effect with medications. SSRIs, or our selective serotonin reuptake inhibitors, are first-line treatments in most cases of unipolar depression as well as anxiety. We generally, for the non-psychiatrists, want to avoid them if there's a bipolar depression so as not to trigger hypomania or mania. Following the SSRIs, many treatment algorithms look to the SNRIs or serotonin norepinephrine reuptake inhibitors, such as venlafaxine, duloxetine, or desvenlafaxine, which use the same mechanism as a selective serotonin reuptake inhibitor or SSRI, but also add in noradrenergic reuptake inhibition. SSRIs and SNRIs are generally very comfortable for doctors in primary care settings to prescribe. However, if a patient needs additional assistance beyond these classes of medications, that is often a good time to involve a psychiatrist on referral. This slide looks at different medical circumstances that can affect pharmacologic intervention. For example, if a patient has a general medical problem that's causing their reactive depression or anxiety, treating the medical problem would be an appropriate way to also treat the depression or anxiety. If it's something that's caused by medications or substance, likewise, it makes sense to adjust or discontinue the offending agent. Some specific examples or cases where we'd want to be more careful include cardiac disease. In cardiac disease, we would want to avoid tricyclic antidepressants, as well as other medications with adverse cardiac effects. Why do we want to avoid tricyclics? It's often because they can predispose a person to arrhythmias, and if a person does have underlying cardiac problems, we want to be especially careful with anything that can prolong the QTC interval. In respiratory insufficiency, we want to avoid respiratory depressants or benzodiazepines. So if you see a patient with asthma or COPD or emphysema, we would certainly want to avoid anything that can make it harder for that patient to breathe. Finally, for liver failure, we want to avoid, for example, non-conjugated benzodiazepines. In general, LOT or lorazepam, oxazepam, and temazepam are considered to be more safe to use in patients with hepatic insufficiency or liver problems. In cases of liver failure, we would also want to avoid medications that are extensively hepatically metabolized, such as valproic acid, also known as divalproex or Depakote. Now, somatization, if we go back to our key vocabulary, we'll remember that somatic means having to do with the body. And if a patient comes in with unexplained physical symptoms, that doesn't necessarily mean that it's by default a psychiatric issue just because we can't make a physical diagnosis or we don't know how. The table on the left identifies a number of somatic symptom disorders, which we're going to dive into in much greater detail in the behavioral health and psychiatry course that will, for the students intended for this talk, you'll get in the next month or so. The differential diagnosis when a person comes in with some unidentified somatic complaint is that it could be a normal concern, it could be a general medical illness, the person might be attention seeking, they might have what's called pantheiatism, or they're hypersuggestible. Maybe they saw something on TV or somebody told them, hey, you should get this checked out, and now they believe they have it. It could be due to psychiatric illness, and they also might be some voluntary things where the patient is predisposing themselves to having that issue. Somatization, or a preoccupation with bodily symptoms in itself, should not be considered a psychiatric disease, nor evidence of psychological instability. If that were the case, many of us who have gone through medical school and diagnosed ourselves with many different things at different points would arguably be guilty of somaticizing. However, the doctor should also know that patients with somatization also have higher morbidity and mortality than those without. And forgive me, I think there's a typo on that slide, but we'll roll with it. You get the point. If a patient comes into the emergency room or clinic with unexplained somatic symptoms, it makes sense to treat them as you would with any other patient. We want to characterize those complaints and concerns, perform physical exam and labs when appropriate, as well as document any presence of depression, anxiety, psychosis, or substance abuse, as well as pursue any inconsistencies in the findings. For example, if a patient comes in with intense right upper quadrant pain, but they have a negative ultrasound and negative metabolic panel, it might make us consider different etiologies than, say, gallbladder issues. Tests are important to think about, but also not to order to excess. Tests may be important to educate, to diagnose, and yes, even sometimes to alleviate anxiety, especially if it's a reasonable test to perform. Reasons we might avoid tests are due to cost. If the risks of the test outweigh the potential benefits, for example, if the test is invasive or dangerous, or if there are any issues with the patient having just completed the test recently and having it be unlikely that there is a more recent change. Now, if a patient does have a somatization disorder, again, an issue that can't be explained medically, but for some reason they're focused on things going on with somatic symptoms, reassurance is important. They should also try to maximize their time with one doctor, usually a primary care doctor, because referral to numerous specialists can be costly and unnecessary. The point of primary care in many of these cases, among so many other purposes, is to really limit the need for unnecessarily costly or invasive testing, as well as to maintain a general level of triage for the healthcare system as a whole. Every patient, for example, who has a headache does not need to see a neurosurgeon. We should limit tests and psychiatric and medical treatment, including medication, unless there are objective abnormalities. Also, working with patients with somatization or an intense focus on their body could have improved rapport and improved therapy efficacy after working with a doctor who's willing to work with them and explore different symptoms in a meaningful way, taking the patient's symptoms seriously, but also setting boundaries for what's appropriate and what's not appropriate with regard to their testing. Let's talk a little bit about lab. When we're going into lab today, or when your lab might be related to the specific pre-work, I'd like all students in the lab to be able to perform a basic mental status examination. Now, a mental status examination may include specific questions, for example, about suicide risk or homicide risk, as well as, for example, what the patient's mood is, which is always subjective. The patient tells you what their mood is, and then the doctor decides what the affect is. We'll talk more about that on the next slide. The student should be able to discern a mental status exam from a conversation, where many aspects of the mental status examination, as our physical exam, so to speak, or our specialty exam that we do in psychiatry, many of those details that we would get from just a normal conversation. Every student should be able to integrate screening tools, including the many different screeners that we referenced in this section, in this discussion. I want you to think widely about the differential diagnosis based on the patient's history. For example, if you have a patient with depression, is it medical? Is it psychiatric? Is it reactive to something going on in their life? Is it part of another disorder? Or is it a combination of all of these things? Same questions if a patient presents with anxiety. Is it something that's medical in nature? Is it psychiatric? Is it reactive? Or again, is it due to another disorder? Remember that depression and anxiety are highly comorbid and often do overlap in the same patient. This slide is a refresher that the mental status examination, not to be confused with the mini mental state examination, the latter of which is an assessment for cognition and a screener for dementia, the mental status examination is the specialty exam in psychiatry. And the specialized exam will allow you to begin your practice now and next year in your psychiatry course. And I should say for our second years in your psychiatry clerkship. The mental status examination, because it is a specialty exam, it goes in the objective section of your note or your physical exam section of your note, even if some components of the mental status examination or the MSE are subjective in nature. I did link an example from the American Academy of Family Practice journal that goes into much more detail about specific components of the mental status exam. Again, I'm not expecting any students as a result of this discussion or the lab to be experts in the mental status exam, but you should be very familiar with what the different parts of the exam are and what facts may fit into certain parts of the exam. For example, if a patient presents and they tell you that they've been thinking a lot about how difficult their exam is that they're having in the practicing physician course, you should know that that would go in the thought content part of the mental status examination, whereas the thought process would describe, for example, that they were very tangential or circumstantial in telling you about that. Psychiatry, again, is full of a very rich and beautiful vocabulary for being able to exactly capture what's going on with a patient. My residency training director, Dr. Lewis, would tell us the purpose of a mental status exam, besides, of course, documentation and tracking where the patient is at, is so that a doctor would have such a good idea of a patient's presentation that they could walk into a busy waiting room and, based just on the mental status exam, be able to pick out the exact patient about whom the mental status exam was done. On this slide, I do talk about insight and judgment. Please be familiar with the differences between each of those things, as well as how you might evaluate a patient's insight and judgment. As we wind down this slide set, I wanted to put in a final plug on the language of medicine. Mental health diagnoses and their treatment can be incredibly stigmatizing. And I really want to emphasize with our students, please don't be a part of that stigma. Please don't make things worse for your patients, for those who serve our patients, or even for ourselves as we go to seek out mental health services. Mental health does not need to be stigmatizing, and the language that we use is such a big part of this. So I want to emphasize that you use language that puts people first and not their diagnosis. It views psychiatric and substance use disorders as well as their treatment as medical and promotes treatment and recovery while avoiding negative stereotypes and biases. For example, instead of referring to a patient as a schizophrenic, that is now a patient with schizophrenia, or a 35-year-old man with schizophrenia. Instead of referring to a person's use of drugs as addiction or a bad habit, that's a substance use disorder, and that's the proper diagnosis in the DSM. Instead of talking about compliance, which is very controlling from the doctor's perspective of if a patient is or is not compliant with your orders. Talk about whether or not they're adhering to their treatment. It's up to the patient, and one of their core ethical principles is patient autonomy. We also don't want to refer to tests such as urine drug screens or toxicology as clean or dirty, because that can imply hygiene issues or morality issues. Instead, we name the specific findings. The urine toxicology was positive for cocaine and opioids. A final one that I really want to emphasize is moving away from the language of saying that a patient committed suicide. Committing something implies that it's a crime or a contract or something like that. Instead, a way that we can respect the patient is to say that they died by suicide, the same as if we were suggesting that a patient died of any other cause. This concludes our discussion for our second year, the Practicing Physician course directed for osteopathic medical students who are learning about psychiatry in their clinical skills course. This is a reminder that this discussion is not meant to be entirely inclusive in the sense that it's meant for about a 1-hour exposure in class and about a 2-hour lab. Medical students, of course, are encouraged to follow through with a complete course in psychiatry to better understand and expand upon the many topics that are listed here. I thank you for your attention and want to wish you the absolute best ahead with your studies.